afternoon, everybody.
Good afternoon, sir. கேக்குது சார்.
கேக்குது.
ஓகே.
வாய்ஸ் ரொம்ப லோவா இருக்கு சார்.
ரூட்டிங் வாய்ஸ் லோவா இருக்கா?
லோவா இருக்கு.
இப்போ
ஓகே சார்.
ஓகே.
Better sir.
3:20 now.
ஒரு 5 minutesல அலோவ் பண்ணிடலாம் எல்லாரும்.
All other hall coordinators are ready.
எல்லா ஹாலுமே ஓகே தான்.
இல்ல ஹால் C ல யாரும் வரலையே.
ஆமா, ஹால் C ல வந்து இன்னும் கணேசன் டீம் இஸ் yet to come.
ஆமா, நான் மட்டும் தான் இருக்கேன்.
நான் இப்பதான் பார்த்துட்டு வந்தேன். எனக்கு ஒரு ஃபோன் அடிச்சிடலாமே.
ஹால் B லயும் PhD கணேசன் மட்டும் தான் இருக்காரு. ஜட்ஜஸ் எல்லாத்தையும் வர சொல்லுங்க. கோஆர்டினேட்டர், சப் கோஆர்டினேட்டர் யாரும் வரல. ஹால் ஏல எல்லாம் வந்துட்டாங்களா சப் கோஆர்டினேட்டர்ஸ்?
Dr. Sivaprasad is online.
Okay. And one more person?
Judges like Kannan வந்திருக்காப்டி, சாந்தி வெயிட்டிங்ல இருக்காங்கன்னு நினைக்கிறேன்.
ஆமா. சாந்தி is on the waiting.
Good afternoon.
ரெண்டு பேர் சாந்தியும் கண்ணனும்.
ரைட்.
அடுத்த 1 hour தான் அமுதாராணியும் மகாராஜன் சாரும். மகாராஜன் சார் ஃபோன் பண்ணாரு, நான் வந்துருவேன்னாரு. கரெக்டா?
ஓகே. அமுதாராணியும்
கழிச்சு அவங்கள ரிமைண்ட் பண்ணிக்கலாம்.
ஆமா, ரிமைண்ட் பண்ணிடலாம்.
Good afternoon, sir. Good afternoon, sir.
வந்துட்டாங்க. 100 வயசு.
Good afternoon, sir. Good afternoon to everybody, sir.
Good
afternoon, sir.
Good afternoon, madam.
Good afternoon, sir.
தஞ்சாவூர்ல இருந்தா வயசு குறைஞ்சிருமா தஞ்சாவூர் மெடிக்கல் காலேஜ்ல?
ஹலோ நான் ஒருத்தர் இருக்கேன் சப்போர்ட் பண்றதுக்கு அவங்களுக்கு மேடம்.
நிறைய பேர் இருக்கீங்கப்பா. பட் வேலை அப்படி பெண்ட கழட்டுதுன்னாங்க. அலைய பிச்சுட்டு அலையணும் அப்படின்னு.
ஜிபி சார் தஞ்சாவூர் தான்.
நானே இருக்கேன்.
ஆமா சார்.
Good afternoon, sir. Good afternoon, sir.
Good afternoon, ma'am.
தஞ்சாவூர்ல வேலை பார்த்தா வயசு குறையுமா?
இல்லப்பா, வேலை அவ்வளவு வேலை அங்க 2 ஹாஸ்பிட்டல் தனித்தனியா இல்ல. ஒர்க் ரொம்ப
heavy work, sir. heavy extraordinary.
சர்ஜன் டாமினேட்டட் காலேஜ் வேறப்பா.
ஆமா சார்.
ஜஸ்ட் ஒரு வார்த்தை பேச விட மாட்டாங்க.
ஆமா சார்.
அதெல்லாம் கிடையாது.
கேட்டு பாருங்க சாந்திட்ட.
ஹலோ.
ஆமா சார். சார் உண்மை சார். செல்வா சார் சொல்றது உண்மை சார்.
ஹலோ பண்ணல இல்ல.
Pieces which.
Hello.
Kripa, I am attending another meeting parallel. That's why.
Okay. No problem. ஹால் C ல வந்து சேகர் மைக்கேல் வந்து பார்ட்டிசிபென்ட் லிஸ்ட் இருக்காரு. கோஹோஸ்ட் லிஸ்ட் கொடுத்தீங்களா சுதர்ஷன்? கோஹோஸ்ட் லிஸ்ட் for hall C and hall B.
Yes, everything is ready.
Because I can see some of the judges in the participant list.
See, Ganesan, co-host, everything has been given.
Okay. Right. You can display the topics to now.
I'll allow the participants of this session.
Yeah. Yes.
ஸ்டார்ட் பண்ணுங்க.
Only participants are allowed, sir. No audience.
யார் வேணாலும் வரலாங்க. ஆடியன்ஸ் பார்க்க வேண்டாமா?
இல்ல, audience can watch, but
all participants are in, sir.
They will be in, sir.
இல்ல, ஒரே பிளாட்ஃபார்ம் தானப்பா.
Everybody will be.
We can admit everybody.
I think headset இருக்கு. Headset.
I think we can start the preliminary review.
24.
Sudarshan sir.
Yes, I'm here.
320.
Yes, sir.
324 தானே ஆறுது.
ஆமாம்.
324.
Shilpa, you can admit all the waiting persons.
Yes.
There are 8 people are in waiting room.
Yeah, we'll admit everyone now.
Yes.
Admit all. I have included. I saw Madhusudan waiting in one of the halls.
Hall B.
Dr. Madhusudan in hall B.
Yeah.
So அவரை அட்மிட் பண்ணிடலாம். அவர் ஒரு ஸ்ட்ரிக்ட் ஆஃபீஸர் கோவப்பட்டுருவார். என்ன உள்ள விடலை.
Hall A 25 participants, Hall B 17, Hall C 30.
ஸ்கோர் சொல்லுவீங்களா அப்பப்ப? யாரு?
எலெக்ஷன் ரிசல்ட் சொல்ற மாதிரி சொல்றாரு.
நாங்க அப்படின்னா என்ன வேற மாதிரி கொண்டு வந்திருக்கோமே ஆளுகளை.
எங்க லாரியில கூப்பிட்டு வர முடியும்?
எங்க இருந்தா இது என்ன ஜூம் தானே?
லாரி தேவையில்லை.
ஆளுக்கு 2 GB வேணா வாங்கி கொடுக்கணும்.
யாருக்காவது ஆஸ்திரேலியா ஸ்கோர் தெரியுமா?
ஆளுக்கு 2 GB டேட்டா வாங்கி கொடுத்துடலாம்.
நெக்ஸ்ட் மந்த் ISA மீட்டிங்ல நாங்க ஸ்விக்கி கூட ட்ரை பண்ணிட்டு இருக்கோம்.
அப்படியா?
பிரியாணி கொடுக்க.
என்ன கொடைக்கானல் ஒர்க்ல ஆரம்பிச்சீங்களா?
கொடைக்கானல் என்ன செய்வோம் கிருபா? எல்லாம் முடிச்ச பிறகு உட்கார்ந்து பேசணும்.
மண்டேல இருந்து ஆரம்பிச்சிடலாங்க.
இருங்க, மீட்டிங் போட முடியுமாங்க?
போடலாம். அதான் டூரிஸ்ட் பிளேஸ்ல ஓபன் தானே.
பண்ணலாம். பேசணும். இன்னொரு இந்த இது முடிச்சு ஒரு வாரம் கழிச்சு ரிலாக்ஸா பேசணும்.
இன்னும் 7 months இருக்குல்ல?
7 months இருக்கு. பட் ஆனா முதல்ல வேலை ஆரம்பிக்கணுமே. ரெஜிஸ்ட்ரேஷனும் ஸ்பான்சர்ஸ் எப்படி வருவாங்கன்னு தெரியலையே.
Sponsors will be a problem.
எல்லாரும் எப்படி ஃபீல் பண்ணுவாங்க, கவர்மெண்ட் எப்படி பிஹேவ் பண்ணும், என்ன இதுன்னு யாருக்கும் தெரியல. ஒரு அன்சர்டனிட்டி இருக்கு. So that
2 more minutes. 3:28. I think we can go ahead. You have first hour, everybody. We can start. Krupakaran?
Yeah. Okay.
Start பண்ணலாம்.
தம்பி,
We can go live.
பென்சில்.
Shall I?
Yeah.
3:27. Okay.
I'm going to mute all.
Yeah.
Over to the coordinator.
I'll be initiating the process. Good afternoon, everyone. We are happy to welcome all of you for this PG, Tamil Nadu ISA PG Conclave 2020. For the last 10 days or so, our team is working very hard to make this program very memorable and successful to all of you. And I'm happy to welcome all the coordinators, sub-coordinators, judges, delegates, and the participants for this PG Conclave. This program will be conducted simultaneously at 3 halls, Hall A, Hall B, Hall C, and you will be aware that the links are given separately through WhatsApp since yesterday evening itself. So if you want to visit any of the halls, you click that link and visit the halls. So with that small introductory note, we will move on to the main session. Now I invite our President, Dr. Sudarshan, to give a welcome address. Dr. Sudarshan, please.
Good afternoon, everyone. It's a great and proud moment for ISA Tamil Nadu. As you all know, we have been quite consistent in standing on what we promise. And this is no different, this event. We promised to conduct postgraduate opportunity to present papers and the posters, and we stood by that, and our team, as Dr. Kripa mentioned, has really worked very hard to stitch up this program and present to you. And most importantly, we are very, very happy that our own postgraduates from our state and the nearby states and those who are living in the other states aspiring to present papers the guidelines of the university and medical council, they didn't get much of an opportunity because of the pandemic due to the lack of conferences held. But then we wanted to break that and wanted to have an online presentation schedule, and we concurred with the medical council and as well as the Tamil Nadu Medical MGR University. Medical University had just at that time to provide the credit points for the postgraduates and the delegates for presenting papers and posters. So that is a real boon for the postgraduates, so that straight away they get 30 credit points from the university, so that their mandatory requirement for the year will be complete. This was the primary reason why we scheduled this program. And I'm quite thankful to our academic coordinators, Dr. Edward Johnson and Dr. Kumar, our president-elect, who have brought in all the team of Dr. Selva Kumar, Dr. Ganesan and Coimbatore, Dr. Ganesan, Trichy, and the entire team of judges who have voluntarily accepted to participate in this event. It is a great occasion for ISA Tamil Nadu to sort of mark it on our completion of the calendar with a lot of pride and real happiness. And I'm happy to welcome our guest for the senior, I won't say a guest, one of us, our member, our governing council member, Dr. Ganesh Prabhu, who's here with us and who will be sharing his words of felicitation with us. And thank you, sir, for joining this program, and all the delegates, of course, who have joined for this event today, and the postgraduates. You just have a comfortable time presenting to you. All your recordings are ready, and you need to be present at the time of question session. At the end of the entire 3 days, what will happen, I think our academic coordinators will explain to you. With that little note, thank you so much. Enjoy your 3-day session of presenting papers and posters. More importantly, sit and listen. Don't try to run away after your session is over. Please attend and encourage and learn from the presentation by the other postgraduates. All 3 days are open for you. We deliberately wanted to keep this an open forum, and then you are benefited by that. I'm very sure about that. Thank you so much. Have a good day. Thank you.
Thank you, Dr. Sudarshan. Now I invite our GC member for National ISA from Tamil Nadu, Dr. Ganesh Prabhu sir, to give the felicitation address. Sir, Dr. Ganesh Prabhu sir. Yes, sir.
Ganesh Prabhu sir, unmute பண்ணிக்கோங்க.
Sir is already unmuted.
Yeah, I think he's
Lost the internet connection.
Am I audible?
Yeah, audible.
Yeah.
Hello?
Yes, sir.
Audible?
Yes.
Hello?
Yes, sir.
Yes, sir.
Please, sir. Go ahead, sir.
Hello?
Go ahead. We can hear you.
Hello?
பேசுங்க.
You go.
Yes, sir. Please, sir.
Hello?
பேசுங்க. கேக்குது. Yes, sir.
Connection are there?
Yes.
கேக்குது, sir. We are listening. சொல்லுங்க.
We are waiting for you to talk.
கேக்குதா கிருபா?
பேசுங்க, கேக்குது.
நீங்க பேசுங்க, நீங்க கேட்கவே வேண்டாம், நீங்க பேசுங்க.
Think we can skip and then.
Yeah.
Okay. சார் பேசுங்க. ஹலோ பேசுங்க சார்.
கேக்குதா?
கேக்குது சார்.
Yes.
Okay. We'll move on.
We'll invite him when he is
Middle of the session. Okay.
during the session.
Thank you. Thank you, sir. Now, our time, we have already exceeded 5 minutes, and now we'll move on to our academic session. I hand over this session to Dr. Edward Johnson and Dr. Kumar and other scientific committee members, Dr. Selo Kumar, Dr. Ganeshan of Trichy, and Dr. Ganeshan of Coimbatore, to conduct the program.
Hello?
Over to our academic committee. Dr. Edward, please. Edward, please.
Thank you, the President and Secretary. I welcome you all to the Tamil Nadu Postgraduate Conclave 2020. So after a hectic activities for 1 month, we are now at the door of great event. I thank my
wishes for the conference.
Working hard to this
Best wishes.
Beginning of this academic event. I wish all the participants great success to achieve to get the prizes. With that, Kumar, we declare that.
Start. He starts, sir. No problem. We'll straight away start. Already late. Yes. We'll proceed, sir.
Okay. I declare the academic event get started. Thank you. Over to the Dr. Selo Kumar. Dr. Selo Kumar.
Good afternoon, everybody. I call upon Dr. Sivaprasad, Senior Assistant in Madurai Medical College, to take over this session.
Good afternoon, everybody. Let us go straight into the scientific session. For the session, I invite Dr. Kannan Bojraj and Dr. Shanti Palraj ma'am to come to the dais for being the judges, and welcome all the participants, Dr. Ramya, Shruti, Belinda, and Dr. Vasavi. Dr. Kannan Bojraj did his MBBS, DA and MD in Madurai Medical College. At present, he is the professor and HOD of TNISA Medical College. He is the president of ISA TNI branch, and his area of interest is in pain medicine. He has done his pain from the pain clinic training, and he is interested in pain medicine. And he has done an excellent COVID work in TNI Medical College. Shanti ma'am has done his, her MBBS and MD in Tanjavur Medical College, and now she is the professor and HOD of Tanjavur Medical College. Her special interest is in pediatric anesthesia. She is a member of Indian Association of Pediatric Anesthetists. Her special interest in pediatric anesthesia is in pediatric laparoscopy. She has been a famous speaker in all CMAs and conferences, and yes, she has got many publications in her name. We welcome both the judges. Welcome ma'am, welcome sir. We'll go straight to the first presentation. First, we'll have 3 presentations by Dr. Ramya, Dr. Shruti, and Dr. Vasavi. Over to their presentations.
Thank you.
Okay. Let's start the video.
Children undergoing infraumbilical surgeries. Caudal epidural block is one of the most popular, reliable, and safe techniques in pediatric analgesia that can be used along with the general anesthesia for intra and postoperative analgesia in patients undergoing infraumbilical surgeries. It reduces the requirement of inhaled anesthetics and opioids, attenuates the stress response, facilitates a rapid, smooth recovery, and provides good immediate postoperative analgesia. Although it is frequently used in pediatrics because of large variation of each patient's body habitus due to age, it can be difficult to predict the puncture depth to reach the space. Therefore, blind technique is more difficult with more failure rates. Ultrasound could be of much greater value in the young pediatric population when there is limited ossification, thus allowing good visual resolution of anatomy and block-related equipment or solutions. Our study was to compare the efficacy of ultrasound-guided and standard conventional caudal epidural block techniques in children undergoing infraumbilical surgeries by comparing the duration of the procedure, ease of application of block, level of postoperative analgesia, need for rescue analgesics, and complication rates. It was a prospective comparative study done in Narayana Medical College, Nellore. Inclusion criteria include children between the age group of 4 to 10 years of both sexes undergoing infraumbilical surgeries, weighing less than 20 kgs belonging to ASA 1 and 2 categories. Exclusion criteria includes children with suspected coagulopathy, infection at the site of caudal block, history of developmental delay and neurological diseases, skeletal deformities in the caudal region. 60 pediatric patients scheduled for elective infraumbilical surgery were divided into 2 groups of 30 each, Group A and Group B. Standard general anesthesia protocol pediatrics was followed. Following general anesthesia, patients were rotated to left lateral recumbent position. Group A, caudal block was performed using standard conventional method. In Group B, with ultrasound guided method, block was performed with 0.5 ml per kg of 0.25% of bupivacaine with 1 mic per kg of clonidine. Statistical analysis was performed using SPSS version 20. Continuous variables were expressed as mean and standard deviation. Intergroup comparison was done using students' t-test. P-value of less than 0.05 was considered as statistically significant. Results: there were no statistically significant difference in the demographic and baseline parameters and duration of procedure between the 2 groups. None of them were excluded from the final analysis. Hemodynamic parameters were comparable in both the groups. Coming to number of attempts required for successful block, majority of the block were successful on first attempt in both Group A with 80% and Group B 70% with an insignificant p-value of 0.476. Post-operative pain scores were assessed based on the flag scale. The mean pain scores were comparable in Group A and Group B at the beginning, 2 hours, 8 hours and 12 hours, 16 hours, 20 and 24 hours. However, at 4 hours, pain scores are significantly low in Group A compared to Group B. Number of rescue analgesic doses in the study, majority of the children required single rescue analgesia dose in Group A 70% and Group B 76.67% with an insignificant p-value of 0.386. Duration and requirement of rescue analgesia. The mean duration of post-operative analgesia, that is 9.26 plus or minus 6.73 in Group A, 9.33 plus or minus 5.85 hours in Group B with an insignificant p-value of 0.968, and number of rescue analgesic doses, that is 1.07 plus or minus 0.63 in Group A, 0.83 plus or minus 0.46 in Group B with an insignificant p-value of 0.11 were comparable in Group A and Group B. Our study concluded that both ultrasound guided and standard conventional caudal epidural block techniques are equally efficacious with respect to duration of postoperative analgesia and requirement of rescue analgesics. However, standard conventional caudal epidural block is associated with shorter duration of procedure. Perhaps if 2 qualified anesthetics are available, the duration of ultrasound guided technique can be reduced. The conclusions drawn from the study are based on single center study involving relatively smaller sample size. Hence, further multicentric studies involving large sample size and in cases where the detection of sacral anatomy is difficult, especially by palpation, may extend the usefulness of ultrasound technique. These are my references.
Kannan sir.
I think we can go ahead with the next presentation by Dr. Shruti Padmaraju. And after the next presentation, we can have an question answer session. Thank you, ma'am.
Good morning, everyone. I'm Dr. Shruti, MD postgraduate in Narayana Medical College, Nellore. My study is about comparison between 15 mg of 0.75% ropivacaine versus 10 mg of 0.5% levobupivacaine in elective cesarean sections. For the past few years, 0.75% ropivacaine is being used for subarachnoid block in lower segment cesarean sections. Of late, levobupivacaine, a levoisomer of bupivacaine, which has less cardiotoxicity than bupivacaine, is being increasingly used for subarachnoid block in lower segment cesarean sections. This is a prospective randomized observational study. After taking consent from Institutional Ethical Committee and from the parturients, 60 SA2 parturients were randomly divided into two groups who are scheduled for elective cesarean sections. Group R received 15 mg, that is 2 ml of 0.75% isobaric ropivacaine, and Group B received 10 mg, that is 2 ml of 0.5% isobaric levobupivacaine. Hemodynamic parameters, onset and duration of sensory and motor block are recorded. Statistical analysis was done with SPSS 20 version. P-value less than 0.05 is considered statistically significant. These are our results. Onset of sensory blockade is faster in levobupivacaine group compared to ropivacaine group. In levobupivacaine group, it is 2.36 minutes. In ropivacaine group, it is 2.56 minutes. Onset of motor block is also faster in levobupivacaine group, that is 4.5 minutes. In ropivacaine group, it is late. A late onset, that is 8.4 minutes. Duration of sensory blockade is less in ropivacaine group compared to levobupivacaine group. Duration of motor block is lesser in group R, that is ropivacaine group, compared to levobupivacaine group. In ropivacaine group, it is 84 minutes, and in levobupivacaine group, it is 119 minutes. P-value is less than 0.05, which is statistically significant. Hemodynamic parameters, that is heart rate, blood pressure, are well maintained in both the groups. Discussion. Clinic et al. Compared 0.5% levobupivacaine and 0.5% ropivacaine in combination with 1:2 lakh epinephrine for axillary brachial plexus block and found that sensory analgesia was significantly longer with levobupivacaine than with ropivacaine, but ropivacaine patients showed a faster recovery of motor function. Hesati et al. Also compared the efficacy of continuous popliteal sciatic nerve block produced with 0.2% ropivacaine with either 0.2% or 0.125% levobupivacaine in patients receiving hallux valgus repair and reported no differences in degree of pain both at rest and during motion. But patients receiving 0.2% levobupivacaine less frequently showed a complete recovery of foot motor function as compared with 0.2% ropivacaine on 0.125% levobupivacaine. In our study, ropivacaine provided clinically effective surgical anesthesia with hemodynamic stability for lower segment cesarean sections. Delayed onset of motor block and early recovery from motor block are observed with 15 mg of 0.75% ropivacaine when compared to 10 mg of 0.5% levobupivacaine, which provided early ambulation after surgery. These are our references. Thank you.
Next presentation.
Yeah, we can go to the next presentation by Dr. Perimala Vasavi.
I'm Dr. Perimala Vasavi. I'm leading with comparison of efficacy of intrathecal fentanyl and intrathecal tramadol as adjuvants to hyperbaric bupivacaine 0.5% in elective cesarean section patients. Subarachnoid block is the preferred technique for cesarean section. It is easy to perform, rapid onset of action, involves lesser drug doses, produces minimal high neonatal depression, lesser incidence of chemical pneumonitis. It also has disadvantages which include producing only a fixed duration of anesthesia, causing intraoperative hypotension and difficulty in controlling the height of the block. Hyperbaric bupivacaine is the most common drug used in spinal anesthesia for cesarean section. Addition of opioids to the local anesthetics is routinely done in central nudaxial blockade as it provides better intraoperative and early postoperative analgesia. Besides offering a good sensory blockade, intrathecal bupivacaine produces a hemodynamic instability, pain, discomfort, and may require analgesic supplementation in early postoperative period. To overcome these drawbacks, opioids are administered intrathecally along with bupivacaine. There are numerous benefits like stable hemodynamics, denser analgesia, lesser pulmonary complications, earlier ambulation of patients, fewer pulmonary complications, prompt return of bowel function, and reduced stress response. My primary objective was to study the duration of postoperative analgesia, and secondary objective was to study the intraoperative hemodynamic changes. This study was done among patients undergoing elective LSCS under subarachnoid block in Katuri Medical College, Guntur, over a period of 1 year. 60 patients were selected. A randomized double-blinded trial was started. Statistical analysis, sample size collection was done based on previous study with difference of 66 minutes and standard deviation of the 61 minutes. So 25 patients per each group will need 90% of the power and 5% significance. So 30 patients will be included in each group to avoid possible dropouts. Statistical analysis was done by independent t-test, Mann-Whitney U-test, chi-square test, whichever is applicable. My inclusion criteria was ASA grade 2, age group of 18 to 35 years, body mass index between 18.5 to 24.9 kg per meter square. Exclusion criteria was refusal to spinal anesthesia, ASA grade of 3 and above, allergic to local anesthetics and adjuvants, infection at the needle site, contraindications to subarachnoid block like bleeding tendencies, gross spinal deformities. Patients were randomly divided into 2 groups by computer-generated list of random numbers. Group 1 received 0.5 hyperbaric bupivacaine 9 mg plus 10 mg of tramadol intrathecally. Group 2 received 0.5% hyperbaric bupivacaine 9 mg plus 0.2 ml, that is 10 micrograms of fentanyl intrathecally. Coming to results, duration of analgesia in fentanyl is 9.47 hours compared to tramadol, which is 6.4 hours. Difference between groups are statistically significant with p-value of 0.03. Coming to pulse rate, the mean and standard deviation of the pulse rate of the fentanyl and tramadol was plotted. The statistically significant difference was assessed by using independent t-test. P-value was less than 0.05, which is considered significant. P-value for pulse rate where various intervals were insignificant. This is a table showing the pulse rate differences. Coming to discussion, we have evaluated the efficacy of the intrathecal fentanyl and intrathecal tramadol as an adjuvant to hyperbaric bupivacaine 0.5% in elective cesarean section patients. We studied the onset of the sensory and motor blockade and duration of the sensory and motor blockade. We studied the quality of the analgesia in terms of pain score and total analgesic requirement, sensory characteristics, motor characteristics in patients receiving bupivacaine with tramadol and bupivacaine with fentanyl. We also studied the hemodynamic changes, incidence of nausea, vomiting, pruritus in 2 groups. Fentanyl, a lipophilic opioid, is a strong mu and kappa receptor agonist and 100 times more potent compared to morphine as an analgesic. Tramadol is an opioid which acts centrally but 5 to 10 times less potent than morphine. Sanjul Dandona et al. Conducted a study consisting of 50 patients, concluded that duration of the sensory and motor block and duration of the postoperative analgesia was significantly prolonged in fentanyl group compared to the tramadol group. In a randomized control study by Manulan Theodore et al. Among 30 patients, they concluded that intrathecal fentanyl is superior when compared to the intravenous ondansetron for the inhibition of the perioperative nausea throughout the cesarean delivery with subarachnoid block. Further, intrathecal fentanyl gives improved perioperative pain control and is less costly than ondansetron. Coming to conclusion, both the groups were effective in providing adequate surgical anesthesia and hemodynamic stability, but fentanyl seems to be a better alternative to tramadol as an adjuvant to spinal bupivacaine in elective surgeries. These are my references. Thank
you. Good presentations. The
first presenter.
The presentations are open to discussion.
You can call Dr. Ramya, the first presenter.
Yes, sir.
Okay. I have done the caudal epidural block by conventional ultrasound guided. You have not mentioned the which frequency probe we have used for the study.
Sir,
what is the frequency of the
13 hertz?
You have not at all mentioned in this presentation. What is the probe, linear probe or collinear probe, and what is the frequency used?
Linear probe with a 6 to 13 hertz frequency, sir.
And can you describe the zone anatomy of the caudal epidural space? What you have seen with your linear probe?
Yes, sir. We will see both the sacral hiatus and sacrococcygeal ligament will be.
Madam, please mute everybody else except the presenter. So much
Sir, already are muted. All are muted. Please, presenters, if you are joined with other devices, please mute. Ramya, yours others have you joined with other system? Okay.
Noise is so much. Hello, proceed. Ramya.
Sir, by keeping the ultrasound probe, we can visualize both the sacral carno and the sacrococcygeal ligament will be there, sir. By penetrating into the skin and subcutaneous tissue, we can see the penetration of sacrococcygeal ligament with the ultrasound visualizations.
And you have used this one single drug that is 0.5% bupropion, but you have compared this drug for the duration of analgesia.
Yes, sir.
How your study is going on? You are giving the so much too much approach to the caudal epidural spaces by two methods, by using
Yes,
the
sir.
single drug, but you are comparing the same drug with the duration of analgesia, whether it is correct or not.
Sir, my the intention is whether the standard conventional technique is a blind technique, sir.
You can
So,
it's not audible. Hello, it is not audible.
sir, audible, sir.
Ramya?
Audible, sir.
Okay.
The intention whether the duration of analgesia will be more or similar in both a blind technique and ultrasound guided. In ultrasound guided, we can exactly identify the space, whereas in blind technique, there may be many anatomical variations in the sacral hiatus, so that we compare the duration of analgesia.
That denotes that you have the failed block. If it is needle is not in the caudal epidural space,
Yes.
that is called failed
Yes,
block. You cannot compare this duration of
block
analgesia by using this one single drug.
Yes.
Okay, Madam Shanti, Madam. Hello, Shanti, please unmute, Madam. Unmute yourself and talk.
Am I audible, sir?
Okay.
Am I audible, sir?
Audible.
Audible. Ramya?
Ma'am.
Your ultrasound guided in your methodology, you have mentioned that you have intubated, you have placed the LMA and you have turned the child to lateral position and you reduced the sevofluorine concentration. What was the maintenance in your case? Did you paralyze the baby or you continued with spontaneous? And with the spontaneous, you performed the ultrasound guided nerve block. How did you maintain the anesthesia in your child in this case during your ultrasound block? During your block, performance of the block?
High concentrations of sevoflurane, ma'am.
No, you have said that you have reduced the concentration to 1 to 1.5%.
After the block the concentration of sevoflurane was reduced to maintain the anesthesia.
So, were you comfortable with the baby with the spontaneous respiration, with the mask, with the sevoflurane? Were you comfortable in performing ultrasound guided block? Okay. How did you confirm the correct placement of needle by ultrasound guided caudal block? How did you confirm?
By looking at the ultrasound image of piercing the sacrococcygeal ligament, ma'am.
Okay, what was the change in the image after injecting the drug? What was the change in the image after injecting the local anesthetic? Did you see any change in any specific change?
The spread of the drug can be visualized.
So the turbulent of the flow can be seen by real time. You can see that whether the drug is going inside the caudal epidural space or not. That is the most important advantage that is claimed by ultrasound. Okay.
You can see the elevation. You can see the elevation of the sacrococcygeal ligament on injecting the drug.
Yes, ma'am.
Okay. So what is the disadvantage with using the ultrasound guided?
I mean, in other words, what is the limitations of this ultrasound guided technique?
Many were not versed with the ultrasound technique, and it with being a single anesthetist, it may be difficult with ultrasound guided. so that an assistant anesthetist should be available, ma'am.
Okay.
That is in the learning period. Okay, no problem. The limitations are in the ultrasound guided technique. You cannot be sure about whether the needle is in the intrathecal space or whether it is in the intravascular space. That is the major limitation. That is not confirmed by our ultrasound. Okay. Okay, thank you very much. Another question is there, madam?
No. The other limitation is your ultrasound image will be masked by the overlying bony structures. So it is not the best method to do a caudal block.
Any other approaches are there for the caudal block? Anything other than this ultrasound, Ramya? You can do it by fluoroscopy. Okay. What is the image in the fluoroscopy? In the fluoroscopy picture, how will you? Where is the point of needle entry guided by our fluoroscope? Anything else? This indentation is there. Oh. Okay, thank you. Next speaker, call upon the next speaker.
Dr. Shruti.
Shruti. Okay. Shruti.
Yeah. Good afternoon. Good afternoon, sir.
Madam, you can start.
Yes, sir. Your study is comparative between 15 milligram of 0.75% ropivacaine with 10 milligram of 0.5% levobupivacaine. Yes, okay. So in the conclusion, you have said that delayed onset of motor block and early recovery from motor block are observed with 0.75% ropivacaine. Can you explain that?
Duration of motor block is less in ropivacaine group, ma'am, compared to levobupivacaine group. So less duration motor block was seen, ma'am.
What happens to the onset of motor block in ropivacaine?
Sir?
So, onset of motor blockade by using this ropivacaine?
Onset of motor block was within 2 to 5 minutes, sir.
And sensory blockade?
Sensory block 2 minutes, 2.4 minutes.
Both are almost same.
Yes, sir. Sensory is 2 minutes, sir. Motor is 8 minutes.
So, what are all the advantages claimed by using this ropivacaine in cesarean section?
It is less cardiotoxic, sir, compared to levobupivacaine group, sir. And early ambulation can be done, sir, because of less duration of motor block.
So here this ropivacaine and you are comparing this levobupivacaine, both are less cardiotoxic, okay. But this ropivacaine and levobupivacaine, the onset of sensory block is same or not?
Yes, sir, same, sir. Levobupivacaine group, it is faster, sir. Ropivacaine group, it is slower onset.
Ropivacaine group, it is slower. Why it is slower, ropivacaine?
It is less lipophilic, sir. So,
which one is? Ropivacaine.
Ropivacaine, sir.
Ropivacaine is less lipophilic. That is why the onset of sensory blockade is prolonged. I mean, late.
Yes, sir.
You are confused, I think. Okay, madam, you can proceed.
Yes. Yeah, your conclusion says that the duration of motor blockade in ropivacaine is 84 minutes and in levobupivacaine it is 119 minutes. Am I correct?
Yes, ma'am.
But your conclusion says delayed onset of motor blockade is advantageous. How does delayed onset of motor block is advantage?
Shorter duration of motor block, ma'am.
No, you have delayed onset. I am talking about onset. See your conclusion.
You are doing this cesarean section. This surgery needs very good adequate laxation or not for delivering the baby? Is needed or not? Yes.
Yes, sir.
And delayed onset of motor placard is advantages, disadvantages. What is your opinion? Can you get the point or not?
Is it advantage or disadvantage, Shruti? Shruti?
Shruti. Shruti is there and gone out?
She joined.
I think gone out.
She
Sir,
joined back.
coordinator, sir. Prasad.
Yes,
Whether
sir.
Shruti joined or not?
Join back,
She
sir.
joined back. Joined back.
Join back, sir.
Or we can call the next speaker. Shruti.
I think some net issues, sir. She's joined back, but her connectivity is not there. We can, sir. Can we go for the next participant's question, sir?
Oh, okay. Madam, please, madam.
Dr. Vasavi Perimala.
Yes.
Madam, please proceed.
Yes, sir.
What is your study?
Fentanyl versus tramadol.
Okay.
Is it?
Yes, ma'am. Yes, ma'am.
Okay. Your result shows that the duration of analgesia in fentanyl group is 9.47 hours.
Yes, ma'am.
And compared to tramadol, which is 6.4 hours.
Yes, ma'am.
We have used only 10 microgram of fentanyl.
Yes, ma'am.
What is the maximum recommended dose of fentanyl for intrathecal injection?
Around 25 mics per 25 mics, ma'am.
Do you think that 10 mics of fentanyl will increase the duration of analgesia by more than 3 hours?
Okay. Basically, whether the fentanyl is lipophilic or non-lipophilic drug?
Lipophilic.
Vasavi. Lipophilic means and it is short-acting drug or long-acting drug? Fentanyl.
Short-acting
drug. So short-acting, highly lipophilic, early onset will prolong the sensory blockade of the hyperbaric bupropion, fentanyl. That is the idea of behind using this fentanyl as an adjuvant for intrathecal opioid.
Yes, sir. Yes, sir.
What are all the advantages to be? Yes, whether it is increasing the duration of sensory blockade.
Yes, sir. It increases the sensory blockade and all. But my study was based on mostly post-op analgesia, sir. I concentrated on
that is prolonging the sensory blockade. What you are telling is prolonging the sensory blockade. Okay.
Yes, sir.
So 10 mics of fentanyl is prolonging for 9 hours.
Yes, sir.
That is
based on
study.
Yes, sir. Previous studies were showing fentanyl was a little better, sir.
What scale did you use? Did you assess by any pain scale or?
Visual analog scale.
Okay. Did you observe the same average of 9 hours post-op analgesia with 10 mics of fentanyl?
Yes, ma'am. 8 to 9 hours duration average with me.
And what is the maximum dose of fentanyl can be used in the intrathecal group?
22 to 25 mics, sir.
25 mics, okay. With this 10 mic, it is increasing the duration, prolong the duration up to 9 hours. It is not possible, I think. It is not possible. And if you inject the fentanyl into the subarachnoid space, the volume of distribution is very high and the duration of action is reduced. And you are adding fentanyl not for the increasing the duration of sensory blockade, but for increasing the quality of the subarachnoid block. What are the quality of the block that are increased by using adding this fentanyl with intrathecal as an intrathecal opioid? What are the qualities that are all improved?
Action will be faster.
Can you got me?
Faster onset of action.
Action will be fast. Very good. What happens to the analgesia? Analgesia is very intense. What happens to
Yes, sir.
hemodynamic stability?
Hemodynamic stability will be hemodynamic changes will
Very
be less.
good. It is
Hemodynamic changes are less.
very stable.
Will come. Yes, sir.
And what is the requirement of the local anesthetic needed?
The dose also will be reduced when.
These are all the qualities. Yes. Okay, these are all the qualities that are all improved by using this fentanyl as an adjuvant in intrathecal route.
Adjuvant
okay.
response. Yes.
And actually, 10 miles will not prolong such a long duration of hours. Actually, it is not possible, I think. Madam, you can proceed.
Yes,
Anything
even 25 mics of fentanyl, the maximum recommended dose will prolong the post-op analgesia by only 30 to 40 minutes. So it's highly unlikely that 10 mics of fentanyl will prolong your analgesia by 9 hours.
And what are the other complications you have faced by using this fentanyl and tramadol as an intrathecal route? What are the disadvantages you have?
There are no much complications, sir, because it was both the hemodynamic changes were not much seen in the patients.
Apart from hemodynamic changes,
sedative effect is also less, sir. So there was no much complications with this.
Did you observe any post-operative complication with these two drugs? What are the commonest post-operative side effects of fentanyl or intrathecal tramadol or fentanyl? You
sedation,
didn't.
Respiratory depression.
No. In your study, you didn't observe any side effect.
No, ma'am. Some patient, like very minute, ma'am. Some 5 to 10 patients complained shivering, but in tramadol group, they were less, ma'am.
Straightforward, I will ask you one question. What are the complications of intrathecal opioids? Can you enumerate? Hello, can you able to follow me? What are all the adverse side effects of intrathecal opioids? Unless you know about that, you will not monitor postoperatively. It is not possible.
Respiratory depression. Sir.
Common side effects.
Respiratory depression. What are the common side effects, sir?
Nausea, vomiting.
Respiratory depression, that is by our opioid-induced respiratory depression.
Nausea,
can you enumerate
vomiting,
how it will be? Nausea, vomiting, pruritus. Is very good. And then? Urinary retention.
Urinary retention and chest wall rigidity in rare cases.
Okay.
Just shall we move on to the next session?
Okay,
we are already we are running short of time.
Okay, Shiv.
Okay. So Prasad, next. You can start the
thank you. We shall move to the next presentations by Dr. Padma Rubini and Dr. Belinda Cherian.
Yeah.
I am Dr. Padma Rubini, finally a postgraduate from Medical College. I am presenting a paper on comparison between pre-bifurcation and post-bifurcation approach of ultrasound-guided popliteal nerve block in foot and ankle surgeries. Ultrasound-guided popliteal nerve block in foot and ankle surgeries conventionally perform proximal towards bifurcation. With the help of ultrasound, we can visualize the bifurcation site and the branches of the sciatic nerve for performing the block. Hence, this study was planned to evaluate the efficacy of the two approaches, that is pre-bifurcation versus post-bifurcation. Aim of the study is to compare the anesthetic efficacy of pre-bifurcation and the post-bifurcation approach of ultrasound-guided popliteal nerve block. The primary objective was to estimate the duration of onset of complete surgical anesthesia. The secondary objectives are to estimate the block performance time, success rate, the rate of onset of sensory and motor blockade, and procedural complication. Sample size is calculated as 30 patients in each group by this formula, considering a difference of at least 25% in onset time of surgical anesthesia as clinical significant. This is a prospective randomized comparative clinical study. 60 patients fulfilling the inclusion criteria undergoing foot and ankle surgeries were randomized into two groups. Group B is pre-bifurcation group and Group D is post-bifurcation group. All standard preoperative procedures were carried out. A standard local anesthetic mixture of 30 ml containing equal volume, that is 15 ml of 2% lignocaine with epinephrine, 5 microgram per ml, and 0.5% bupivacaine was prepared. Patient was placed in lateral position with hip and knee slightly flexed and supported with pillow. High frequency linear probe with frequency setting of 13 MHz and a depth of 3 cm was selected. Probe was placed parallel to the popliteal crease in transverse position with caudal tip. In this level, you can locate the pulsating popliteal artery at 3 cm depth, and it is confirmed with ultrasound Doppler. Superficial to the artery lies the popliteal vein, which is confirmed by the increased venous flow by squeezing the calf muscle. Superficial and lateral to the vein lies the tibial nerve, which has a honeycomb appearance. By traceback technique, neural bifurcation is identified by sliding the probe upwards. Neural bifurcation is identified as hyperechoic structure in bilobular pattern as depicted in this picture, and it is confirmed by the seesaw sign. Dorsiflexion and the pantaflexion of the foot causes the tibial and the common peroneal component to move up and down. As standard procedure, Group B patients receive block 5 cm proximal to the bifurcation. 30 ml of the local anesthetic mixture is injected around the nerve in circumferential manner via in-plane approach using 23 gauge spinal needle. In Group D, block is performed 3 cm distal to the bifurcation, where 15 ml of the drug is injected around the tibial nerve and 15 ml around the common peroneal nerve in a circumferential manner via in-plane technique with single needle entry. The sensory motor block were evaluated every 5 minutes till complete surgical anesthesia is achieved. A compositive sensory motor score was calculated. A score of 8 indicates complete surgical anesthesia. Time taken to obtain a score of 8 was defined as onset time of complete surgical anesthesia. Statistical calculation was done by SSP software 20. In our study, demographic data, block performance time, and success rate were comparable between two approaches. The onset time of surgical anesthesia was significantly shorter in the post-bifurcation group with a time of 18.5 minutes. This is the graph that represents the rate of onset of sensory and the motor blockade. In this, blue line represents the post-bifurcation group and green line represents the pre-bifurcation group. In this, you can note the rate of complete sensory and the motor blockade was significantly higher in the post-bifurcation group, which I have depicted in this red box. At 20th minute, 80% of the patient in the post-bifurcation group had complete sensory block, and 55% of the patient in the post-bifurcation group had complete motor block. Thus, the rate of surgical anesthesia was significantly higher in post-bifurcation group. There was no vascular puncture and no difference in the incidence of accidental paresthesia. Usually, the onset time for ultrasound-guided sciatic nerve block is variable, and it is 30 to 40 minutes. This delay is due to large size of the sciatic nerve as well as the presence of paraneural sheath, that is local sheath outside the epineurium. In our study, we note a 40% difference in onset time of surgical anesthesia. A major factor attributing to this difference is the nerve diameter. As the nerve bifurcates, the minimum distance to the core fiber of the tibial and the common peroneal nerve is halved. So the diffusion time for the local anesthetic to reach the core fiber is faster in the post-bifurcation approach. Thus, the onset time is quicker. These are the literature reviews supporting my study. Sala Bench et al., Prasad et al., Jamanian et al., and Bice et al., who concluded that post-bifurcation approach has rapid onset. My conclusion is separate tibial and the common peroneal nerve block distal to the bifurcation of the sciatic nerve is as effective as pre-bifurcation block with rapid onset and least complication. Hence, post-bifurcation block is also safe and reliable technique for ultrasound-guided sciatic nerve block in popliteal fossa. These are my references, and I thank ISA Tamil Nadu for giving me this opportunity.
Let us move on to the next presentation by Dr. Belinda Cherian.
I'm Belinda presenting to you a randomized control trial to compare preemptive with postoperative ultrasound-guided mandibular nerve block for postoperative analgesia in mandibular fracture surgeries. Introduction: ultrasound-guided mandibular nerve block is effective for providing postoperative pain relief in mandibular fracture surgeries. The preemptive nerve blockade prolongs the duration of postoperative analgesia and reduces the consumption of intraoperative opioids. Primary objective was to compare the consumption of morphine for 24 hours postoperatively. Secondary objective was time for a request for rescue analgesia, intraoperative hemodynamic parameters, additional fentanyl consumption, and VAS score. Inclusion criteria included ASA status 1 and 2 between 18 and 70 years of age, patient scheduled for unilateral mandibular fracture surgeries under general anesthesia. Exclusion criteria included fracture of symphysis, pregnancy, patients allergic to local anesthetic, coagulation abnormalities, chronic cardiac, hepatic or renal diseases, and patient refusal. This prospective randomized double-blinded control study, after obtaining institutional ethical committee approval, was registered in Clinical Trial Registry India. Randomization was performed using computer-generated random number and placed in a sealed opaque envelope. At the start of surgery, envelope was opened by anesthesiologist administering the case and allocated to one of the group. This is the picture of ultrasound-guided mandibular nerve block, which was performed by placing the probe parallel to the zygomatic arch, and perimandibular space was identified, and using an outplane technique, needle was targeted around maxillary artery and 10 ml of 0.5% ropivacaine was given. Fentanyl 2 mites per kg was administered before induction and repeated at 1/3 of the initial dose if there was an unexplained increase in heart rate or mean arterial pressure by more than 20%. Number of patients requiring additional bolus doses of fentanyl was recorded. The patient was shifted to PACU and managed by another anesthesiologist who was blinded to the group involved. The patients were monitored for vitals 24 hours. VAS score was used to assess pain, where 0 is no pain and 10 as the worst pain. The patient was started on PCA with morphine. The bolus dose was kept at 1 mg with 10 minutes as lockout interval, and the baseline infusion of 0.1 mg per hour was given. The patient was instructed to use a bolus dose when VAS score was more than or equal to 3. The total consumption of morphine was recorded. The time for request for rescue analgesia was taken as the time consumed from extubation to the first bolus consumption of morphine. The VAS scores were compared every 4 hours for 24 hours. The patients were observed for any side effects. Sample size estimation was based on pilot study of 10 patients for each group. For study to have 80% power and alpha power at 0.05, a minimum of 27 patients would be required in each group to detect a 20% difference in consumption of morphine between the two groups. We recruited 30 patients in each group to compensate for the possible dropouts. Statistical analysis was performed using SPSS software. The categorical variables were tested using Fisher's exact and chi-square test. The continuous variables were tested using an unpaired t-test. A p-value less than 0.05 was considered to be statistically significant, and less than 0.01 as highly significant. This is the concert chart depicting the passage of participants through a study. No patients were lost to follow-up. There was no difference in age, sex, ASA, physical status, and duration of surgery between the two groups. Total morphine consumption was more in group B when compared to group A, and duration of postoperative analgesia in group B was lesser than that of group A. In group A, only 4 patients required an additional dose of fentanyl as against 11 patients in group B. Perioperative heart rate in group A was lesser than that of group B, from 45 minutes to 120 minutes. There was no statistically significant difference in perioperative mean arterial pressure between the two groups. This was a study published by Indian Journal of Anesthesia in 2018 that concluded that ultrasound-guided trigeminal nerve block reduces perioperative opioid consumption in patients undergoing facio-maxillary surgery with better patient pain score. This is a study published in Indian Journal of Anesthesia 2008, and they concluded that VAS score was significantly lower in group receiving preemptive analgesia for up to 40 hours post-operatively. Limitations: we did not check the exact areas of sensory blockade. We did not check if pre-induction administration of mandibular nerve block improved the mouth opening, which may be restricted due to fracture pain. We did not use it for bilateral fractures. Conclusion: ultrasound-guided mandibular nerve block given before incision reduces the consumption of morphine for 24 hours post-operatively, prolongs the time for request for rescue analgesia, reduces intraoperative fentanyl consumption, better control of intraoperative heart rate, better pain scores post-operatively when compared to mandibular nerve block administered at the end of the surgery. These were the references used, and thank you.
Let us move on to the discussion. Dr. Padmarubini.
Yes, sir. Good evening, sir. Good evening, ma'am.
Good evening.
Madam
Padmarubini, your case is your paper is comparison between pre-bifurcation and post-bifurcation. Am I audible?
Yes, ma'am. Yes, ma'am.
You have mentioned that some cases will be given saphenous block, but you have not mentioned whether all patients received saphenous block or only some of the patients received a saphenous block. It will be,
Based on the procedures, orthopedic procedures, we done the saphenous block, ma'am.
No,
Like
that
distal foot surgery.
That will interfere with the study, no?
You should standardize.
You have to standardize. That will interfere with the study, no? For some cases, you
Otherwise,
perform
you cannot
saphenous
compare
block.
at all.
You cannot do. How can you compare? With some cases of study cases with both sciatic and saphenous, and some cases with only sciatic block. How can you compare?
We only evaluated the sciatic nerves sensory block assessment, ma'am, not the saphenous nerve. We didn't block assessment was not done over the saphenous nerve territory, ma'am. We only assess the tibial and the common peroneal nerve components only. The onset time.
And then next one, you have in the conclusion, you have told that rapid onset time with this bifurcation, post bifurcation, and least complications. What are all the complications you have noted and what are all expected? And what are all the complications least in post bifurcation and more in pre bifurcation? You are not at all mentioned. Can you able to get me?
Yes, we observed about the vascular. We expected vascular puncture and accidental paresthesia, and there is high in our study during the observation. We noted accidental paresthesia is more in pre-bifurcation, but in post-bifurcation we had less accidental paresthesia, sir. So the chance of intraneural injection is very less in the post-bifurcation group. That I have mentioned, sir.
Okay, can you trace the zona anatomy of common peroneal and tibial nerve?
Actually, the popliteal crease level, the popliteal artery is localized. We can visualize the pulsation, and it is confirmed with ultrasound Doppler, sir.
No, I'm asking the zona anatomy of common peroneal and tibial nerve course. In the popliteal fossa. Can you describe?
Yes, ma'am. Yes, ma'am. Superficial and lateral to the artery and the nerve lies the tibial nerve, and laterally on the lateral aspect of the fossa, lateral to the tibial nerve lies the common peroneal nerve.
Okay, actually, what is the recommended point of injection of the local adhesion? You have in your study you have mentioned that around the nerve.
Madam,
yes, ma'am. Around
the nerve, around tibial, around common peroneal. Can you explain?
Yes, ma'am.
What is the recommended point of insertion of needle?
Madam, you have given 30 ml for pre-bifurcation group and 15 ml for post-bifurcation group.
15 ml around the tibial nerve and 15 ml around the common peroneal nerve.
So 30 ml for both group. Okay, by using the ultrasound, the main advantage is you have to reduce the volume of the local anesthetic injected, but you have given this 30 ml as like that of a blind technique. What is the advantage claimed was that was totally knocked off?
Actually, there is a two.
Why have you chosen this large volume? It is not at all needed.
There is two types of injections. One is subparaneural and another is subepimysial, sir. In this, I have injected outside the paraneural sheath, that is subepimysial, because for study purpose only, sir. That is to compare
whatever
the
injection, you have to deposit the drug outside the nerve. Whatever may be, you should not injure anything. You should not inject any local anesthetic into the nerve sheath. It is not at all recommended. It will lead on to peripheral nerve injury and so lead on to so many complications.
Yes, sir.
So injecting the drug just near to the nerve, very few millimeters distance from the nerve, but you are using this high volume. I am talking about this high volume, whether it's really recommended or not.
Sciatic nerve has this paraneural sheath, known as a local sheath. This local anesthetic has to pierce this paraneural sheath and then the epineurium, and then it reaches the core fibers. That's why we use this 30 ml.
So 30 ml is recommended.
Yes, sir. 25 to 30 ml is recommended.
You have visualized the nerve. You have visualized the tip of the needle. We are real time. We are seeing the drug spread, the local anesthetic spread. Still, you are using this 30 ml. How can we accept it, madam? this large volume, 30 ml for that single nerve. Okay. Madam, please.
Sir, can we move on to the next candidate, sir? We just have 3 minutes more for this session.
Okay, Shiva.
Sorry, ma'am.
No
Dr. Belinda?
No problem.
Yes, sir. Can you hear me, sir?
Yeah, you are audible.
Okay, sir.
Belinda.
Mandibular nerve block.
Mandibular
Yes.
nerve block.
Yes, ma'am.
So you didn't mention the approach. What was the approach to mandibular nerve block in your study group?
Sir, ma'am, we mentioned use extraoral approach, ma'am, using ultrasound guided, ma'am. We placed a probe parallel to the zygomatic arch and in the
Okay, it's an extra oral approach.
Yes, ma'am.
Okay, but you have compared two study groups where you have put a mandibular nerve block preemptively in one group, the other group post-operatively.
Yes, ma'am.
How can you compare these two?
Ma'am, preemptive just before the surgical incision is placed and post-operative just before extubation, ma'am. So preemptive is shown to have better post-operative analgesia because we are blocking the central sensitization to the incision, inflammatory injury, ma'am. So preemptive and post-operative we are comparing, ma'am.
Your conclusion is preemptive is better and consumption of morphine and fentanyl is less.
Yes, ma'am.
What was the duration of your post-op analgesia?
Ma'am, duration was around 13 hours for preemptive, ma'am. When compared to post-operative. Post-operative it was around 6 hours and preemptive it was around 13 hours, ma'am.
What was the average duration of the surgery in your case, in your study groups?
Less than 2 hours, ma'am.
So less than 2 hours.
2 hours.
Belinda, you are comparing this preoperative and postoperative nerve blocks. Is it that preventive analgesia?
Yes,
one group you have given 2 hours prior to the block. And the next group you are giving 2 hours later. And you are comparing the prolonged time required for request for SQ analgesics.
Yes, sir.
2 hour gap is there. And you have not standardized very properly, I think. You should do it in a single time and we have to assess the length of postoperative analgesia. And 2 hours prior group, 2 hours prior to block and 2 hours later block. And how can we compare it?
Sir, usually post-operative just before post-operative will have a better duration of post-operative analysis, but this we are placing before the surgical stimulus, sir. So it is known to have preemptive is always known to be better than post-operative, no, sir.
Belinda.
Yes,
Belinda.
Yes, ma'am.
In your conclusion, you have compared the intraoperative fentanyl consumption and intraoperative heart rate.
Yes,
whereas, how can you compare when you are performing the other block post-operatively? How can you compare the intraoperative consumption of fentanyl and intraoperative heart rate? There is no intraop in the second group, no? How can you compare? There is no intraoperative period in the second group. You are performing the block post-operatively. Where is the question of intraoperative fentanyl consumption in the second group? It is not at all possible to compare.
Madam, one thing, Belinda, it is a totally biased study. And we cannot accept it at all because you are doing nerve block 2 hours prior and nerve blocks 2 hours later. And you should not compare what happens to the 2 hours period there. And the standardization is not good. You should not compare it.
Sir, in post-operative, sir, there was a fentanyl consumption was much more in post-operative, ma'am, when compared to preemptive. In preemptive, fentanyl consumption was very much less.
And your study should be like this. With the preventive analgesia and without preemptive analgesia, you can compare the requirement of fentanyl required intraoperatively. You cannot do it with this post-operative block and preoperative block. Fentanyl consumption, it is no point in it comparing these studies. And it's a great bias is there. Okay, madam, you can proceed.
Is there any more questions, ma'am?
No.
Oh, okay.
Okay.
Call upon the next speakers.
That's it, sir. Five presenters. That's all, sir.
That's all.
Yes, sir.
Oh,
We
sixth
have,
one is absent.
Yes, one presenter is Dr. Maunik was absent, sir.
Absent.
we have completed in a correct time.
Correct time, yes, sir. Thank you very much, sir. That was a great opening session. Thank you, judges. Thank you, participants.
Thank you,
all.
Shiva, for excellent
Thank
moderation.
you. Thank you.
Shiva.
Thank you for
Thank you,
all the
ma'am.
participants
Thank you.
and thank you for the ISA.
Thank you. Thank you.
For this wonderful event. Thank you very much.
Thank you, ISA Secretary and all office bearers. Thank you, Selokma sir, for giving this opportunity. We had a great session and I wish all success for PG Conclave. Thank you.
Thank you very much.
Thank you.
Thank you.
We shall move on to our next session of this day. Here we have, I welcome Dr. Harish Kumar, Dr. Pranjali, Dr. Anusha, Dr. Sahiti, and Dr. Tamilaran, who are all going to present in the next session. I welcome Dr. Amudarani ma'am and Dr. Maharajan sir as the judges to the EDS. Welcome, judges. Dr. Maharajan sir is the professor and HOD of Anesthesia, Critical Care and Pain Medicine at Meenakshi Mission Hospitals and Research Center. He is running, I think, the Department of Surgical Gastroenterology owes much to him because he has developed that department very nicely. His field of interest is in expert airway management and enhanced recovery after surgery. He is proficient in transplant anesthesia, advanced hemodynamic monitoring, and robotic surgery. Welcoming you, sir. Dr. Amudarani ma'am. She has done her MBBS and in Madurai Medical College and MD in Coimbatore Medical College. At present, she holds a chair at Professor and HOD at Tirunelveli Medical College. She is the president of Tirunelveli ISA City branch, and she has bagged many awards in her honor, like in renal transplantation. She has organized many noteworthy conferences like Nelcon, TNISA, Pranaswasa, and she has 6 publications till date. And the interesting is that she is a fellow in clinical endocrinology also. Welcoming you, Amida ma'am and Maharajan sir. We'll straight away go into the session. The first 3 presenters are Harish Kumar, Pranjali, and Anusha. Can we have the presentations?
Good morning, everyone. I am Dr. Harish Kumar. I am here to present a comparative study between magnesium sulfate versus dexamethasone as an activity in supraclavicular brachial plexus block. Introduction. Supraclavicular block have been administered at the level of trunk of brachial plexus. It is very reliable method of regional anesthesia for upper limb, and it is called spinal anesthesia of upper limb. Long-acting local anesthetics along with bupivacaine for brachial plexus block provide good operative conditions but have shorter duration of post-operative anesthesia. It is reversibly bind to specific intracellular portion of voltage-gated sodium ion channels in the neuronal membrane, resulting in inhibition of depolarization and nerve impulse conduction and a reversible loss of sensation. Magnesium sulfate is also used as a perineural adjuvant apart from systemic uses. It has been proved to have anti-nociceptive effect by blocking the N-methyl D-aspartate receptor and associated calcium channels, thus preventing the central sensitization that is caused by peripheral nociceptive stimulation. Shown to prolong the analgesic duration of perineural blocks. This effect is due to its local action on nociceptive C fibers mediated through glucocorticoid receptors and anti-inflammatory action. It also suppresses ectopic neural discharge, and this effect is by altering the function of potassium channels in the excitable cells. Aim of the study is to compare and determine the efficacy of supraclavicular brachial plexus block with bupivacaine and adjuvant drug as magnesium sulfate or dexamethasone in upper limb surgeries. Objective is to study the onset, duration of sensory and motor blockade, duration of anesthesia and supraclavicular brachial plexus block with bupivacaine and magnesium sulfate or dexamethasone as adjuvant. To study hemodynamic changes and intraoperative and postoperative side effects or complications if any. Inclusion criteria is patient willing to sign informed written consent, and patient of age greater than 1 of either gender, patient undergoing elective upper limb surgeries and age between 18 to 55 years. Exclusion criteria is patient refusal local infection of site of block, non-allergy of local anesthetic drug and adjuvants, patient with coagulation disorder or on any anticoagulant therapy, patient with systemic disease like heart disease, respiratory disease, etc., and pregnant patients. So a study was conducted on 50 patients undergoing elective upper limb surgeries with successful supraclavicular brachial plexus block with 0.5% bupivacaine 30 ml with the adjuvant as either magnesium sulfate 10% or dexamethasone 2 ml, that is 8 mg plus normal saline 3 ml. The patient was observed after successful block and compared the effect of observation and results. In this slide, it shows onset of time of sensory block and motor block. Group M is magnesium sulfate group and T is dexamethasone group. In magnesium sulfate, the onset of sensory block is 19 minutes, and then dexamethasone group is around 17 minutes. And onset of motor block in group M is 12 minutes, and in group T, it's also 12 minutes. Onset of sensory block and motor block was short in patient who received dexamethasone as an adjuvant. This slide shows effective sensory block and effective duration of block. Group M, the duration of effective sensory block is around 426 minutes, and in group T it's 440 minutes, and duration of effective motor block is 346 minutes in group M, and in dexamethasone group it's 479 minutes. The duration of effective sensory block and effective motor block was more in the patient who received dexamethasone. This slide shows about duration of post-op anesthesia and the time of first rescue anesthesia. Group M, post-operative anesthesia duration is 415 minutes, and in group D, it's 533 minutes. The time of first rescue anesthesia required at 508 minutes in group M, and in group D, it's around 622 minutes. So duration of post-op anesthesia was more and prolonged time of first rescue anesthesia in the patient who received dexamethasone. This slide shows about the side effects. In group T, one patient had nausea and one patient had vomiting. In group M, 2 patients had nausea and 1 patient had vomiting. So minimal side effects are seen in a patient who received dexamethasone. Discussion: the effect of magnesium sulfate as adjuvant on peripheral nerves is based on a surface charge theory, which suggests a modulation of external magnesium concentration resulted in a synergistic effect on nerve blockade due to local anesthetic. Dexamethasone is a steroid. They have a nerve blocking effect by the mechanism that they block non-restrictive impulse transmission along amino-native C fibers. Conclusion: dexamethasone as an adjuvant is highly effective in onset of sensory block and prolongation of sensory motor block and duration of anesthesia. It is superior to magnesium sulfate and provides a better postoperative pain-free period by extending the time required for rescue anesthesia with a steady hemodynamics and without any serious complication. Thank you.
We shall move on to the next paper presentation by Dr. Pranjali.
Topic is the use of dexamethasone as adjuvant to bupivacaine for supraclavicular plexus blockade. The term regional anesthesia was first used by Harvey Cushing in 1901. Dexamethasone has been shown to have greater accessibility than clonidine. In the present study, we use 0.5% of solution of bupivacaine with dexamethasone 30 microgram for conduct of brachial plexus block by supraclavicular route and study the effect of adding dexamethasone on the onset duration, quality of block, and its effect on hemodynamic parameter and complication side effect adding dexamethasone. Our aims will be to observe the effect of adding dexamethasone 30 microgram to local anesthesia solution bupivacaine 0.5% on onset, offset, and character of brachial to observe the postoperative pain-free period, to study the changes in hemodynamic parameter, to study the incidence of side effect. In maternal method, the present study involved observation on 50 patients of age grade 1 and 2 between the age group of 18 to 60 who goes for upper limb surgery. Inclusion criteria: we take the patient with age grade 1 and 2 and age group between 18 to 60 and patient surgery to elective upper limb. We will exclude the patient who refused for surgery, hypersensitive to the drug, infection in the site of block, infertility, serious systemic disorder, women with a pregnant and lactating mother, and other than age group 1 and 2. And we'll study procedure. We will do the pre-answer to check it before the day of surgery, written consent. After counseling, patient will instructed not to take anything for 6 hours, and we'll apply a pre-block vital parameter for comparison after block administration. Time count begin with the time of completion of the injection or as 0 hour. A brachial pressure was performed under aseptic precaution. After eliciting paresthesia, patient will receive 38 ml 0.5% bupivacaine local acid solution with or without 30 microgram dexamethasone. Will evaluate the brachial plexus block by sensory block by tested absence or sensation to pinprick, motor block by evaluating modified Brumett scale is shown here. And after administration, we'll see and record the onset of time, sensory block, onset time of motor block, duration of sensory block, duration of motor block, duration of sensation, and vital parameters. Side effect, we'll see hypertension, bradycardia, and respiratory depression. In observation and result, the present study entitled Use of Dexamethasone as Adjuvant to Bupivacaine of Supraclavicular Brachial Plexus Block was undertaken on 50 patients undergo upper limb surgery under brachial plexus, and various observations were taken, which are follows. In this one line diagram, we shows the mean heart rate. In line diagram shows that variation in heart rate in both groups at different time interval shows that the mean heart rate in patient who did not receive dexamethasone had a high mean pulse rate in comparison to those who received dexamethasone. The observation has shown that the change in pulse rate at time observation was highly significant. In this slide diagram, we'll see the mean systolic blood pressure shows the change in mean systolic blood pressure, although the mean systolic blood pressure remains statistically significantly lower in patients who received dexamethasone with the bupivacaine and brachial plexus block, but it remained within the clinically acceptable limit. So in discussion, we'll see that the bupivacaine has been shown with the various adjuvant, but more commonly with alpha-2 adrenergic receptor agonists like clonidine, dexamethasone. In this study, we compared bupivacaine alone and bupivacaine with dexamethasone 30 microgram. Of the two, dexamethasone has high affinity for alpha-2 receptor 800 times than clonidine, then therefore procedure similar effect in lower dose than clonidine. Peripheral action of dexamethasone is mediated by 4 proposed mechanisms. These are centrally mediated analgesia and decrease in central sympathetic outflow causing hypotension and bradycardia, direct action on a peripheral nerve on alpha-2 receptor, and attenuation of inflammatory response. In this table, we clearly show that the onset time of sensory block is very less in group B than A, as well as in the motor block also there is less time taken by group B people than group A. The bar diagram shows that the onset of and offset character of brachial plexus, the mean onset time of sensory block in group A was observed was 19.5 minutes, and for group B is 17.2. We also that a time of motor block in group A and B was that respectively. In this table, we'll see that the duration of effective sensory block is more in group B than group A, as well as the motor block is also more in group B than group A. In this table, we'll see that time of first rescue anesthesia is early in group A than group B. Bar diagram show that the duration of post-operative anesthesia in both groups indicate that the completed surgery could be finished without need of supplement anesthesia, as in minimum and maximum time of surgery were within the range of effective anesthesia without movement of limb. The time for demand of dose of rescue anesthesia by the patient in both group was 90 plus minus 47.9 minutes and 938 plus minus 141 minutes, significantly higher in patients who received dexamethasone. Thus, analysis show that this finding is highly significant. Summary: the present study entitled Use of Dexamethasone as bupivacaine for supraclavicular was carried in 50% who undergo upper limb surgery. In this present study, we saw that the effect of addition dexamethasone to local anesthetic solution on block character, quality and duration of anesthesia, and postoperative pain period compared with those patients who received bupivacaine alone. The finding of present study allow us to conclude that the addition of dexamethasone 30 microgram to 30 ml of 0.5% bupivacaine for conductive of brachial plexus block favorably shorten the onset and offset time of block and provide a prolonged postoperative pain-free period that was statistically and clinically highly significant without any serious complication. Thank you.
Thank you. The next presentation is by Dr. Anusha.
Effect of intravenous ondansetron on spinal anesthesia induced hypertension and bradycardia. Spinal anesthesia is simple, reliable, most common anesthetic technique, which has the side effects of hypertension, bradycardia, and shivering. Mechanism under this is decreased vascular resistance caused by the sympathetic blockage, which in turn causes vasodilatation, finally leads to drop in the arterial pressure. Parasympathetic overactivity and activation of visual gyrus reflex and increased baroreceptor activity may lead to hypertension and bradycardia. BGR is triggered by chemo and mechanoreceptors, which are serotonin sensitive. Serotonin is an additive trigger for the BGR in hypovolemic patients. Ondansetron has 5-HT3 antagonizing effects with minor side effects such as headache, agitation, and confusion. Even though spinal anesthesia is simple, safe procedure, rare complications such as unresponsive hypertension, bradycardia, real anesthetic challenges. It is preferred to prevent hypertension rather than treating it. Spinal anesthesia impairs thermoregulatory control of body with increased incidence of shivering by 56.7%. Serotonin is thermoregulated neurotransmitter which decreases the core temperature and triggers the shivering. Shivering has deleterious effects like increases in carbon dioxide production and increased cardiac work. We hypothesize that blocking type 3 serotonin receptors with IV ondansetron reduces hypertension induced by the spinal anesthesia. Aim of the study is the effect of intravenous ondansetron on hypertension, bradycardia caused by spinal anesthesia as a primary outcome and perioperative nausea, vomiting, and shivering as secondary outcomes. A comparative randomized controlled double-blinded study was done on the patients who was posted for the infraumbilical surgeries. Randomization process of allocating into two groups was done using computer-generated random groupers. Group A patients receives IV ondansetron 4 mg. Group B patients receives normal saline of 2 ml. Drug was labeled by the anesthesiologist who was not involved in the study, and patient was monitored by the different anesthesiologists. Grouping was done in such a way that both patient and monitoring anesthesiologists were blinded to the study, informed